A 35-year-old woman developed sudden, excruciating chest pain, which occurred while going for a run, and then it resolved with rest. She's never had this chest pain before, and the first thing she wants to know is, am I having a heart attack? With chest pain, you can usually figure out what's causing it by asking the right questions, but sometimes further testing is needed. Of course, whatever you see on the internet, including this video, is no substitute for seeking medical attention in real life. With that said, by the end of this video, you'll know my approach to diagnosing chest pain, especially since there are many clues that can give away the diagnosis. So let's get at it. Chest pain can originate from all the organs in the chest: heart, lungs, esophagus, as well as nerves, muscles, bones, and joints. The three most serious lung diseases that cause chest pain include pulmonary embolism, meaning blood clots in the lungs, pneumothorax, where the lung deflates like a flat tire, and pneumonia. And with the gastrointestinal tract, the esophagus can cause chest pain when you have acid reflux, aka GERD or gastroesophageal reflux disease. And this is actually the most common cause of non-cardiac chest pain. Then you have the very common musculoskeletal causes of chest pain like costochondritis. Chest pain often induces anxiety, but the reverse is also true. Anxiety and emotions are often the causes of chest pain, so is it the chicken or the egg? In order to sort out the cause, we have to answer some key questions and understand the context, like age of the patient, past medical history. We need to know things about the specifics of the chest pain, like its character, its duration, and the exact location. What makes the pain worse? What makes it better? For example, is it better or worse when sitting up or lying flat? How about when you take in deep breaths? And of course, what are the associated symptoms like shortness of breath, cough, back pain, fever, all very important. Chest pain that originates from the heart can almost always be boiled down to one of five things: a heart attack, angina, arrhythmias, aortic stenosis, and pericarditis. Angina refers to chest pain that occurs when the heart muscle isn't getting enough blood flow. It's a feeling often described as a chest heaviness, tightness, squeezing, crushing, constricting, or sometimes burning in the center of the chest or a little bit left of the breastbone. The pain sometimes radiates to the shoulder and arms, typically on the left side, and it can also radiate to the neck and jaw and the upper abdomen. Stable angina lasts less than 5 minutes. Unstable angina, which is the worst angina, that lasts about 5 to 10 minutes, sometimes longer. When it comes to a heart attack or myocardial infarction, this is caused by a plaque in the coronary artery that breaks off, travels downstream, and lodges somewhere, causing a sudden blockage of blood flow to a particular area of the heart. It's overall similar to the chest pain with angina, but usually it's a more intense pain and more likely to feel short of breath, nauseous, have profuse sweating. The pain builds up over minutes and it lasts about 30 minutes. When it comes to a heart attack, do women have different symptoms from men? Not really. Women might be less likely to have chest pain when they have a heart attack, and they're slightly more likely to have severe fatigue as a presenting symptom. Pericarditis is inflammation of the pericardium, which is the sac that engulfs the heart. That can be caused by many things, including viruses, including COVID. Pericarditis causes a severe, sharp, stabbing kind of chest pain that's worse with taking in deep breaths, as well as coughing and sneezing. The other unique feature about this chest pain is that it's worse when lying down and better when leaning forward. The pain doesn't really go away until it gets properly treated. Aortic stenosis refers to the aortic valve of the heart hardening with age and subsequent narrowing of the diameter, where blood is pumped from the left ventricle of the heart going to the aorta. So it's a tighter, narrower space there. When this happens, there's also less blood flow that goes to the coronary arteries, since the coronary arteries stem from the base of the aorta. Ultimately, this can translate into less blood flow going to the heart. This doesn't make for a happy heart, and this myocardial ischemia can cause chest pain similar to angina. And like with angina, the more you exert yourself, the more likely you are to elicit that myocardial ischemia and hence chest pain. So giving things a rest will make the pain go away. There's many different types of arrhythmias, some are more concerning than others, but regardless of the kind of arrhythmia, the heart becomes less efficient with its ability to pump blood. This can lead to myocardial ischemia and associated chest pain. An aortic dissection. It's a serious condition in which a tear occurs in the inner layer of the aorta, the biggest artery in your body, which stems from the left ventricle of the heart. With an aortic dissection, blood rushes through the tear, causing the inner and the middle layers of the aorta to split, hence the term dissection. Depending on its severity, it can be fatal. An aortic dissection will present with abrupt chest pain that is excruciating, like a ripping or a tearing sensation, which almost always radiates to the upper part of your back between the shoulder blades. With a pulmonary embolism, meaning a blood clot that travels to the arteries of the lungs, that can cause a heaviness sensation in the chest, and often people feel short of breath with a typical abrupt onset. Sometimes a pulmonary embolism can result in a section of the lung not getting enough blood flow, and that part of that lung tissue can die off. And this is called a pulmonary infarction, which is the lung's equivalent of a myocardial infarction. When this happens, patients will often have pleuritic chest pain, meaning it hurts more when taking a deep breath, hurts more if you're having coughing, hurts more if you sneeze. The lung that has the pulmonary infarct is where that pleuritic chest pain is going to be located. Also, pulmonary infarcts can cause people to cough up blood. Speaking of pleuritic chest pain, something else that can cause it is pleuritis, inflammation of the lining of the lung, inflammation of the pleura, which is most often due to pneumonia. So if you have a left-sided pneumonia or a right-sided pneumonia, that's where your pain is going to be if you have pleuritis. That's going to be a pleuritic type of chest pain, meaning it's worse with deep breaths and coughing and sneezing. And also with a pneumonia, you're more likely to have other symptoms like shortness of breath, cough, fever, coughing up stuff, and so forth. Pneumothorax is when the lung deflates like a flat tire, and it can happen for a number of reasons. But this is almost always going to cause someone to have a sudden, sharp, stabbing type of chest pain that is going to be a pleuritic type of chest pain where it's worse with deep breaths. Most people with a pneumothorax are also going to feel short of breath and have a fast heart rate. Now to the esophagus. Let's say you do a dangerous TikTok trend like eat pureed ghost peppers like this guy did in California, which led to severe retching and vomiting to the point of tearing a hole in his esophagus. Well, this is a life-threatening condition called Boerhaave syndrome, and that's going to present with excruciating sharp chest pain that radiates to the back, and then you go into septic shock, which is sometimes fatal. Boerhaave syndrome can also happen if you have an endoscopy, but thankfully, that's pretty rare. Much more common is acid reflux, which can cause a burning, dull, tightening pain, sort of mimicking angina, which lasts minutes to hours and is provoked by bending, straining, or lying down. This chest pain can also happen with other issues with the esophagus, such as esophageal spasm and esophagitis, meaning inflammation of the esophagus. What about musculoskeletal causes? Of course, chest pain is obvious when someone has trauma and breaks ribs and so forth, but one of the most common causes of chest pain is something called costochondritis, where you have inflammation of the cartilage where the ribs are meeting the breastbone. It's usually caused by sudden heavy exertion like lifting heavy objects or performing a movement that puts a lot of sudden force in the chest. This chest pain is usually worse with taking a deep breath and coughing and sneezing. And unlike the other things that cause chest pain, this chest pain is usually reproducible, meaning you can reproduce the pain by pressing on it or it'll feel worse when you press on it. And to our final type of chest pain, it's issues that are brought on by the nerves that go there. So, for example, things like thoracic outlet syndrome, intercostal neuralgia, and spinal cord compression. This type of pain is a tearing or a burning sensation or an electrifying pain, and it's usually associated with numbness and tingling. What if you get varicella zoster, the virus that causes shingles? Well, sometimes that's going to affect these nerves that go to the chest. And if it does so, then this pain often precedes the shingles rash, and that skin is very sensitive to touch. Also, you can have psychological origins of chest pain, for example, when it's brought on by anxiety or panic attacks. So what about our 35-year-old woman who's developed sudden, excruciating chest pain while running? We know that it resolved with rest, and no, she did not eat a bunch of ghost peppers beforehand. It turns out her pain lasted 5 minutes and was a crushing type of pain in the center of her chest, which did not radiate anywhere. Other than resting, nothing made the pain worse or better. She also had nausea and profuse sweating associated with her pain. Now, she's had several previous episodes of chest pain with activity, but those episodes were much milder. But now she's very concerned about this pain to the point of coming to the ER. Her initial vital signs were normal except for her heart rate, which was kind of fast, going at 110 beats per minute. Oxygen saturation, 100%. With physical exam, there's nothing abnormal with her breath sounds or heart tones. She's in a sinus rhythm. There's no skin rash, and she does not have any chest wall tenderness. She's otherwise a healthy person. She doesn't smoke or drink alcohol or vape or do any drugs. She doesn't take any medications. She doesn't have any close relatives with any major medical problems. Her parents, they're in good health. So what's causing her chest pain? Well, it seems like she's having angina, especially because it occurred while exerting herself when she was running, and it was a crushing type of chest pain that lasted 5 minutes and went away with rest. So she gets an EKG, which other than sinus tachycardia was normal. Chest x-ray, as expected, was normal. A cardiologist sees her, where they take her to the cath lab and they do a cardiac catheterization, where they inject contrast dye to get a close look at her coronary arteries. Her coronary arteries look normal, so she's not having a heart attack. They even gave her intracoronary nitroglycerin during the cardiac cath, which shows no change in the coronary artery diameter. So this indicates that there's no spasm of the coronary arteries, which is something that could cause angina. She has a cardiac MRI done, which shows something peculiar: diffuse perfusion abnormalities. The cause of this patient's chest pain is something called microvascular dysfunction. In women with typical angina symptoms, when they have a cardiac catheterization, more than half of them end up having abnormal narrowing of their coronary arteries, usually due to something called microvascular dysfunction. The very small arteries that deliver blood to the heart, the ones that are usually too small to see during the cardiac catheterization, these arteries are less than 0.5 millimeters in diameter, but they can be problematic and not deliver enough blood to the heart muscle if someone has microvascular dysfunction. And that's a whole nother topic, including its prevention and treatment. But the main takeaway is to pay attention to the different clues of chest pain by asking the right questions in order to get to the heart of the matter.